What's going on, everybody? Welcome to another episode of the Core Consults RX podcast. And this episode is once again accredited for your continuing education credit. Right, yes. Cole?
Right.
Nailed it? Okay.
Nailed it.
So we're back at it today, and happy to do another episode that you can claim your continuing ed credit through freeCE.com. If you have an unlimited membership, you can listen to this episode. Hopefully, we can help you learn some information. Then you take those newly found skills over to their website, which will be in the show notes, and you will do a post-activity test. And then, as long as you pass, which hopefully you will, then you can claim your credit. And if you don't, you can always try again. There's repeats in this class. And if you're not a member, definitely check out their website. For now, the podcast is only associated with the unlimited membership, so that you can't buy individual episodes. But definitely check out their full library of monographs, live calendars, and all kinds of stuff you can check out. There's a lot of information on there, and there's also a discount code if you check out those show notes as well. So check them out. And when you are logging into the post-test activity, it will ask you for a password. The password is going to be pollen, Pollen, all capitals. All capitals is key, and it'll let you in for your test-taking pleasure. But yeah, tonight, allergic rhinitis.
Yes.
So this is a topic. We did this one a while ago, but it's been a minute.
Yeah, it's been quite some time, and it's one that can be revisited for sure.
It sure can.
Yeah, I have to say that
Case
this is
point.
The first episode I've been on with new music, and it's fantastic.
Yeah. Oh, thank you.
Just have to say.
Thank you. But when we switched
I don't want anybody to think that they tuned into the wrong podcast because they heard the wrong intro music.
They were like, "What is that?"
I'm sure they realized by our monotone voices shortly thereafter that
we're back.
It's Mike and Cole back at it.
AJ on the controls as usual. He's okay. We found the soundboard we have now. So we got a new thing for gadget for AJ to play with. So he's back there controlling that. And so I guess we'll jump in this thing, get started, and we'll see how it goes.
Let's do it.
Where do you want to start, Cole?
Yeah, well, we're going to do some basics because we're going to take you all the way through allergic rhinitis, background, drugs, first-line stuff that we might not use as much, and so hopefully you'll have the whole picture of what's available, prescription and over-the-counter. But what is rhinitis? Inflammation, specifically of the membranes lining the nasal passages, right? So you'll hear this termed seasonal allergies. You may even hear the terms hay fever thrown around for something like this. But commonly there's rhinorrhea, nasal congestion, sneezing, itching around the nose and the eyes for sure. So we have medications to combat those symptoms. Some are more effective than others, and some are kind of less effective for specific parts of that, like maybe they don't work as well for the eyes, but they work better for others. So we'll touch on that as we go. You can do a physical exam, and you'll see some things on a physical exam that are characteristic of allergic rhinitis versus something else like rhinosinusitis possibly. But swollen nasal turbinates, plus or minus nasal polyps, the clear rhinorrhea, mouth breathing, so that kind of congestion that leads to mouth breathing, and possibly an acute ear infection that may or may not have effusions along with it, right?
Absolutely. I like mouth breathing. It always makes me laugh.
It does, doesn't it? Because what is that, a colloquialism for like somebody who's unintelligent?
Yeah, I guess.
Mouth breather?
Colloquialism is a good word as well, Cole.
Yes.
I like that.
Thank you.
So seasonal versus perennial allergic rhinitis, because some patients can deal with this, allergic symptoms just at a certain time of year when, let's say, pollen season. Around here where we live, South Carolina, pollen is everywhere. So my car used to be white. Now it has a nice faint yellow color to it because the pollen's very thick.
You know what's terrible?
What's that?
So I got pollen all over my truck during COVID, and
right.
I literally did not drive my truck for like a year because gas mileage, we were just using my wife's. Mm-hmm. We never had to drive at the same time. And so I did not wash it, and so the pollen dried and hardened on, and the paint also mildewed. It was terrible. I really should not take. I should take better care of my truck. And so now there's permanent stains from that one pollen season. Isn't that terrible?
That is terrible.
It just burns me to this day.
I mean,
I got lazy during COVID.
It happens.
Yeah,
happened to a lot of people.
I had to tell you what.
But yeah, so pollen is definitely a big one here. There's also ragweed. There's a bunch of other potential allergies, environmental allergies, or patients can deal with things year round if there's pets or something like that they're allergic to. But because there's various sort of inflammatory mediators and allergic responses that the body kind of has as a result of those allergens, it's kind of a multi-targeted path that we have to look at for treatment options. We tend to think of it as kind of a one-way street, and usually thinking like antihistamines and things like that. But we're going to talk through some of the better treatment options for maintaining symptoms, because you have to realize that it's causing leukotriene production, certain prostaglandins, a release of neutrophils, eosinophils, other cytokines or inflammatory mediators. There's a lot of things going on. And when you have a patient that is dealing with allergic rhinitis, it's also important to assess for comorbidities. So it's not uncommon to find a patient that also has comorbid cases of atopic dermatitis, as well as asthma, are very commonly seen with this. And then, also checking out if they have any risk factors, either in the home or in their environment in which they work or whatever. And it could be something as simple as like the pollen outside and that they have to interact with if they go running a lot or something like that, or on walks at night and they get kind of exposed to that. But it also could be somebody smoking in the house or around them at work or whatever, because it's not always the fact that they're smoking. It could be just passive secondhand smoke, as well as mold, or they could potentially be in the home. Dust mites, that's something that we don't often think about. And then animals, do they have a cat that they're allergic to? And I know you love that cat, but
I do love that cat. Have I talked about that?
You have.
I do.
But if your eyes started itching really bad, would you keep them?
Sure.
Yeah, I probably would
too. Take
something.
Though you mentioned running.
I did.
So you can be allergic to running? That's my new excuse.
I am. No, what happens is you run and the pollen goes because you're breathing very heavily, even though you're barely moving, right? That's my experience. And then that pollen and all that goes very deep into your sinuses and starts the sneezing by the time you finish said run. I'm
going to say, sorry, babe. Just, I know you want me to run with you, but allergies.
Can't do it.
Just can't.
It's too much of a risk.
It's too much.
That's a good one.
So what are we trying to do with treatment? There's a few goals. The biggest thing is, of course, controlling these symptoms that we talked about. But that's not the only goal, because we have drugs that can treat the symptoms but might cause other undesirable symptoms as well. So we want to treat the symptoms of allergic rhinitis and limit the symptoms from the drug. So some drugs cause fatigue, so we want to reduce fatigue during the day. Also improve sleep at night. So controlling those symptoms will help with both those as well. Improve taste and smell, which can be altered with allergic rhinitis, and prevent worsening asthma in patients who have asthma comorbid. Asthma, atopic dermatitis, and allergic rhinitis. Is that the allergic triad, or am I confused by that?
It might be.
Might be. We'll go with maybe.
Yeah.
Okay.
We can Google it.
Thank you. There are some non-pharmacologic treatments. So Mike mentioned my cat, whose name is Bess, whom I love very much. The one option of non-pharmacologic treatment is removal of pets. I'm going to go with not an option for me, but it might be an option for some of you. Washing sheets and pillowcases in hot water, also using high-efficiency particulate air filters can be an option as well.
For those of you who are fancy.
That is pretty fancy.
Our actual pharmacological treatment options are kind of vary as well. Typically, intranasal steroids are sort of the first-line option for most patients. They're going to be considered to be the most effective, and also generally considered by most guidelines to be, like I said, first line over some of the other agents that are also commonly used, but just from an efficacy standpoint and overall control of symptoms, intranasal steroids are usually top dog.
That's an interesting point too, because especially from a patient education standpoint, I don't feel like they grasp that as much. I think most people think of any intranasal allergy medicine to be more local to just like nasal runniness or nasal congestion versus like eye itching and all the rest of the symptoms too. So
that's
important
true.
Point.
Oral antihistamines, although can still be utilized, they can be good alternatives or adjunct therapy as well. Leukotriene receptor blockers, which we'll mention briefly. There's also intranasal antihistamines. There's nasal cromolyn, which is probably not the best option, and we'll talk about maybe a situation where you might be able to utilize that. But we'll kind of break all those down and go into more detail about each class.
Yeah.
But we've all seen the glucocorticoid nasal sprays. There, several of them are over the counter. We have technically 2 different generations of them. We have our first and second. Our first generation would be things like the budesonide, the triamcinolone, which both of those are over the counter now. And then our second generation would be like fluticasone, both propionate and fumarate, mometasone, things like that. And basically the thought is the second generation tend to have lower risk of systemic effects. Not to say that the first generation really is that much of a systemic absorption from a steroid adverse effect standpoint, but just from a overall pharmacokinetic standpoint, the second generation do have less systemic effects, but it's not something with either generation we worried that much about. The good thing is any of the steroid nasal sprays are going to be about the same as far as their effectiveness in treating symptoms and controlling symptoms. And it ends up being kind of like either what the patient's insurance is covering or how often they have to dose it, because that does change from product to product. But ultimately know that they are going to be about the same regardless of what option you go with.
Yeah.
The good thing about the steroids from an intranasal standpoint, obviously, one, we can use them more, thinking about it more almost topically because it's staying in the membrane versus systemic absorption for the most part, but it's going after all of those different inflammatory mediators and the cytokines that are responsible for promoting the inflammation, and it's kind of calming down multiple, things that are kind of targeting or causing the symptoms in the first place. If you see like the Flonase commercial, they talk about that and they kind of throw shade at the oral antihistamines. We're like, oh, that only helps one thing. This goes after 6 things. That's cool. I get it. It does take a little bit though to get the maximum effect of the Flonase, like any of the nasal steroids. And I think that might be where some of the public perception comes from, because usually from like a oral antihistamine standpoint, you can get some really fairly quickly. But really with the nasal steroids, it takes about 3 to 5 days, maybe even a week or so to really get the full effect. Some resources will say 2 to 3 weeks to get maximum effect. It kind of just varies on the product, but just know that it's not going to happen overnight.
Right.
And to tell patients that they need to stick with it, they need to use it every day, and eventually the symptoms will improve.
Yeah, it's funny because I would think that with maybe one of the first gen antihistamines that we'll talk about, or even like cetirizine, when a patient feels something from taking something, so if they feel drowsy, they're going to be like, oh, this is working. I know it must be working for my allergies because I'm getting tired. But the intranasal glucocorticoids are not going to cause that, and so it might be a different perception of response. Interestingly, there can actually be drug interactions with these, even though they're pretty local. So strong CYP3 or 4 inhibitors like itraconazole and nifazodone, there are some case reports of interactions with intranasal fluticasone.
And before you even jump into the next slide, because I think this is a perfect segue into our sponsor of the episode, pearls.com, as always, for our Pearl of the Day. Because you pulled up Flonase, because I was like, you know what, Cole? I don't remember how to administer Flonase properly. I just forgot. So I pulled up.
I have no idea.
I don't. I was clueless, and thank God I pulled this up though, because they have an administration technique step by step that you can kind of walk patients through on the Pearls Drug Information Database. So you can pull up Flonase, and it says step 1, blow nose to clear the nostrils. Step 2, you're going to tilt the head slightly forward, which is actually the complete opposite of what almost every patient does, kind of intuitively.
Oh, it's like when you have a nosebleed and you just
put your head back, and then all the blood goes down the back of your throat.
For everybody on the podcast, I just dipped my head back. Nobody got to see that.
He did. It was good. You guys should have been here. And then step 3, they say place the spray tip about a fourth or half an inch into the one nostril. Hold the bottle upright and aim the spray towards the back of the nose, which is also tends to not happen. And then spray one pump and then sniff gently at the same time. And that's sniffing gently. You don't have to take this huge, big, huge inhale, which, again, I feel like I see patients do sometimes. They inhale like it's their life depends on it.
Just can't help but think of my dad. My dad
is
closes one nostril and
it's go time.
Sucks it up as hard as he can.
That's getting in the back of my brain
That's terrible.
before I leave here. Step 5 obviously is repeating depending on the type of nasal spray that you're using, formulation that you're using. Step 6 is just to kind of breathe in gently as the medication kind of goes deeper, but not to tilt your head back after using the nasal spray, which is another thing. For some reason, people love that. The head tilt, which ends up just making the medication drain down the back of your throat and taste disgusting, which is also noted here. And then when you're finished, wipe off the spray tip with a clean tissue because your nose might be disgusting. And it doesn't say that part. I added that. I was ad-libbing. And then you can store it in a proper place for later. But yeah, that's it's in the Pearls database now. Constantly getting new drugs. So check out www.pyrls.com/coreconsultrx. You can sign up for a free membership, and then if you want all the content released, you can go and do the paid one after that, but there's a version of it that's free with plenty of good stuff.
Love it. Pearl of the day.
Pearl of the day.
I'll definitely say that I'm one who tilts my head back after administration a little bit, and I always end up with it running down my throat, and it tastes absolutely terrible. Because the reason I do it is because otherwise it drains out of the front, which I guess in hindsight is probably more pleasant.
I get ahead of it. I spit it right in my mouth, right? I get used to it, and then it doesn't matter.
Well, the taste apparently
That's
happens...
a joke, by the way. Don't do that for all of you who are going to sue us. That is not true.
This is an accredited episode. We have to say, do not do that.
That is not true. That is a complete joke because we're on a podcast.
Yeah. So the taste is actually something that happens to a lot of people, which I didn't realize as much because it really bugs me about a certain brand. But for patients who have a lot of issues with that taste and want something that might not have that as much, there is Q-Nasal as well as Zetona. These are both dry aerosol delivery systems and will not cause as much of that taste sensation. There's also one that is preferred in pregnancy. Budesonide, Rhinocort may be preferred in pregnancy as well. The adverse reactions are kind of what you would expect. Some local irritation, drying, burning, discomfort, runoff into the throat, like I mentioned. A fair amount of people, up to 10%, report these during use. And it is important to mention that the ones that contain alcohol or propylene glycol are more irritating. So some of those brands would be like Q-Nasal, Flonase, even Zetona contain alcohol and might be a little more irritating.
Yep. So that's the nasal steroids. Let's talk about the oral antihistamines because there are several. There's also generations of these, and the first generations are things like diphenhydramine, chlorpheniramine, hydroxyzine, and then when you move to the second generation, we're talking about the medications like cetirizine, loratadine, fexofenadine, and then we have I don't even know if third generation is the technical term for it. I think it's more slang, but third generation would be like levocetirizine or desloratadine. Basically, those are the newest, more purified options, if you will, versions of the second generation. So basically, these are going to competitively inhibit the histamine 1 receptors, H1 receptors, preventing and binding of histamine. So that's going to help to sort of control some of those symptoms of the allergic rhinitis. However, you are also going to get the rest of the symptoms that go along, or the side effects rather, that go along with blocking that histamine receptor. And those can be the anticholinergic type side effects where you get some blurred vision, you get some dry mouth, you get constipation, you get urinary retention. It could be dizziness. You can get some cognitive or psychomotor performance issues where those can start to be decreased, a lot of sedation. So definitely not without side effects. Now, the first generation antihistamines are going to cross the blood-brain barrier significantly more readily than the second and third generation. And so they tend to be associated with a lot more of side effects. And the one group of adverse effects that patients always complain about is the anticholinergic effects, especially the dry mouth, the dizziness, the fatigue. The fatigue is a big one. If I take a Benadryl, I'm out. Which
does have that paroxysmal effect on some people where they
causes agitation.
Yeah, I remember I would have, like, with this one particular kid when I was young, say that when he got it, that he was like bouncing off the walls, and I was like, "You're lying."
Turns out it's a real thing.
This is a real thing.
I remember seeing this was when I was in pharmacy school, but I was on a plane with Jen at the time, and there was literally like some mom that was like had this kid with her that was going, I mean, nuts, full on, just crazy in the plane, just jumping on stuff, hitting his kid legs, and she's like explaining to the flight attendant, like, "I am so sorry, we gave him Benadryl to knock him out, I don't know what's going on." And I had just had that section in pharmacy school. I was like, "Oh, I know what's going on.
I know what's happening." That's we got to take Nathan on a flight in July for the first time. Yeah,
nice.
Yeah,
that might be your key to get to see the cockpit though.
What, having a kid?
Yeah, because they'll sometimes the pilot will show.
Yeah,
the kid.
but probably not a 1-year-old.
Oh,
you
don't say he has to enjoy it. I'm saying that's your ticket to seeing all those cool buttons.
Yeah, Nathan really wants some wings.
So if you have some, then
if you have some adult size, that'd be great.
You're wearing them. That would be great. AJ, order us wings.
The pilot ones and the real ones.
Yeah. Well,
and the chicken ones.
That'd be good. So the second generation, though, we're not having to worry as much about those adverse effects. We still will have some, but they tend to be considered non-sedating and less anticholinergic effects. That being said, if we had to label one of them as more sedating than others, cetirizine tends to be the one that we get a little bit more complaints about, and it kind of makes sense because the most potent first generation antihistamine is hydroxyzine. And that is actually metabolized into cetirizine. So basically, they took the active metabolite or one of the active metabolites that and made that into its own product, so they could try to cut down on some of those side effects. The problem is, it's still the active metabolite of the most potent antihistamine, and tends to be a little bit more sedating than others, especially if someone's more susceptible to them.
Yeah, you'll definitely hear that. Definitely hear that complaint, and we'll talk about the relative sedation of the other ones as well. But with those first generations, the onset of action is pretty quick, about 30 minutes. I feel like there's a perception that it's like much faster than the second and third gens, but that's not really the case. I think they're about 30 to 60 minutes as well, so pretty much the same. There's really no reason that I can think of to use a first generation over a second generation in a otherwise pretty much in any patient I could think of for allergic rhinitis. But the first generations are lipophilic. They easily cross the blood-brain barrier, like Mike said, and all the side effects that go along with Mike said. And then we already mentioned the agitation as well. So the second and third generations, some notable things. Cetirizine does have dosing down to 6 months old. It's 2.5 milligrams. Prior to that, there's really no other allergy options that are actually medications. You'll see things that are like
little noses and stuff.
Homeopath. Well, I guess that's an actual drug, but there's also like homeopathic things like the Zarbis and stuff like that. But otherwise, it's not actual medications. Levocetirizine is what we would quote unquote call a third generation. It's an active metabolite of cetirizine. Basically, it's equivalent in what it does at about half the dose. People will say that it's less sedating, which is definitely possible, but both of these are more sedating than other second and third generations because of that structural similarity to hydroxyzine, like Mike mentioned. Loratadine, which tends to be the one that I take, is possibly less effective than the others, but I've had people mentioned that they will take one for a while and then they feel like their symptoms are coming back, and so they'll switch to one of the other ones for a while and kind of rotate through. I would say just what works best for the individual patient. Desloratadine is a major active metabolite of loratadine, so similarly it's equivalent, but at half the dose of loratadine. Fexofenadine is the most non-sedating, so if you have somebody who has trouble with even loratadine with some sedation, it's the most non-sedating at even higher than recommended doses, but it does have some drug interactions. It inhibits OAT, so do not take it with any fruit juices.
Yeah, and I think that's the one that, to me, the only one that stands out with that interaction, that organic anion transport polypeptide. That's just my favorite thing to say. Because usually when we think juice, we think grapefruit juice because of the CYP interactions. Mm-hmm. But that's fixafinidine, and I know there's others that do interact with OTEP, but that's an absorption issue because it's actually blocking the transporter that is used for absorption. And I cannot tell you how many times I've talked to patients who have said that Fixative Energy stinks. I don't like that one. It doesn't work. And I ask them how they take it, and they go, I take it in the morning with my orange juice and breakfast.
Yeah.
I go, uh-oh.
So we're going to address that first issue, which is the orange juice for breakfast. And we'll address the second issue, which is the
Who told you that was a good idea? Because that's not.
It's got vitamin C.
Yeah, just take a vitamin C tablet or eat an orange. Anyways, every one of my patients with diabetes that I counsel, it's like, I love orange juice. Like, oh, boy. But so that interaction, and that's any type of fruit juice, whether it's apple, grape, whatever. It's a weird interaction, but maybe if you're drinking
grapefruit,
cranberry,
raisin. That's grape, right?
Yeah. Instantly trying to name as many juices as possible. That's helpful.
Carrot, maybe not carrot.
I don't think it's carrot.
Vegetable?
Yeah, I don't think so.
That's a vegetable juice.
It is a vegetable juice.
Watermelon.
Thank you. Yeah.
Thank you, AJ.
That's true. It is mostly water. It might not have an issue there either.
Oh boy, now it's off the rails. But yeah, so that interaction only applies to fexofenadine. We also have intranasal antihistamines. So we have isolastine and then olopatadine. Typically, olopatadine you think of as like the ophthalmic versions, like Patanol, Pataday. But there is a intranasal formulation as well. And these are a little bit better as far as the side effect goes, because the sedation and whatnot, they're not going to be as widely systemically absorbed, and so you can tend to not have to worry as much about the side effects. However, what they having safety profile or side effect profiles, they lack in efficacy. So they're kind of weaker agents, especially going to be weaker than like the nasal steroids. Those are definitely still going to be first line. They do, however, have the combination products available, and one in particular that's been around for a while is the Mista. It's fluticasone and isolastine together, or you could just prescribe them separately and just have the patient use both. But it's not something that you can't do both of them, but they if you had to pick one, definitely with the nasal steroid.
Yeah, I see these, especially isolastine, used all the time. Where do you think that comes from? I mean, maybe people who've tried the other stuff and it's like they're just moving on to this, because it's definitely not first line for these things.
And at least in my experience, it's usually patients who are doing something like the Flonase or whatever, budesonide, and they're either not using the proper administration technique, so they don't think it's working, or they are not doing the right dose, or they're skipping days and only using them when they need to.
So they might be prescribed that to add on or to replace.
Yeah, and so it's like their adjunct therapy that they're getting. That's how I typically see it being utilized. Yeah. And I think isolastine's over the counter now too. It just went over the counter. I believe so.
Nice.
Well, is it?
Well, yeah, I know. Then more people are going to end up using that instead of something that works a little bit better.
But yeah, I mean, definitely it's out there. I personally would recommend doing the the nasal steroid first, and then if they need an adjunct therapy, then maybe consider an oral antihistamine. Yeah. If that's not an option, you worry about side effects, then the intranasal, because they're not as effective.
Any issues with the oral plus the nasal?
I mean,
not that I can think.
Not that I can think. I'd be more worried about a little bit more
side effects,
anticholinergic effects, because at least you might not be getting so much systemic absorption with just the intranasal antihistamine by itself, but it's just that much more added to it. Yeah.
I agree. So sometimes your nose is stuffy, so sometimes we have to decongest your nose. So we do have some available decongestants, oral and intranasal. Generally, how these are going to act is by being alpha-adrenergic agonists, so that would be considered a sympathomimetic. They cause vasoconstriction, and they decrease sinusoid vessel engorgement and mucosal edema, and that's how they help with decongestion. So we have the big one that everybody's familiar with, which is the pseudoephedrine, branded as Sudafed, because of the Combat Methamphetamine Act. You have to get that behind the pharmacy counter. Generally, it acts as a stimulant, important to counsel patients on, especially with the long 24-hour doses, 12-hour doses even, around sleep. Some people will have some issues with sleep. It's not recommended in patients with hypertension, cardiovascular disease. It can be okay with monitoring and controlled hypertension, but if there's other options, then may be avoided if you're concerned. Patients with closed angle glaucoma, don't use in those patients either. And it's available in a variety of combinations with antihistamine products. So generally, if you see any of those products ending with D, that is going to be the Sudafed. Which is interesting that they chose D as the acronym for all those, isn't it?
Yeah, it is kind of strange. I guess because decongestant, maybe.
Oh, my goodness.
Was that just epiphany for you?
My mind is blown.
Well, thank God I'm here.
I'm like, so there's a D in the middle of pseudoephedrine, and there's a D in the middle of Sudafed, but why was it not P or S? It's decongestant.
It is.
Killing me, Mike.
Dude.
How long have I been a pharmacist?
A long time.
Too long.
Too long to not think.
I did not know that. It's great. Well, here, answer me this. Okay, I already figured it out. So the next one is phenylephrine. Generally is Sudafed PE or will end in PE. But see, with that one, they went based on the name. They went with phenylephrine. It would be PE.
I think the D products came out first, so they were like, "Oh, we'll be clever, do decongest," and then they were like, "Crap, cough," with like DM, like dextromethorphan or whatever. They were like, "I'll just name after the active ingredient." Yeah, they gave up.
Yeah, okay, you can tell why I would be confused, because DM, dextromethorphan, PE, phenylephrine.
I feel like you're very worked up about this.
I think I had more in my favor than the D did.
Well, the thing about me though is I know all the history of these cough and cold products.
Yeah, you were around when they all had their
First of all, that's
origination.
not true. How dare you? I'm so young, right, AJ? Thank you.
AJ says
Me and
right.
AJ are the same age basically.
Well, I should point out that phenylephrine is pretty wimpy,
Yeah.
but
Absolutely.
you'll see it all over the place and used a lot because they don't have to go to the pharmacy counter. And there is some misconception about, sometimes some concern about Sudafed and abuse in some way if it's used as it's prescribed, but there's not. It's just behind the counter because people can abuse it in a different way.
Yeah.
Right.
Yeah. Sometimes you got to cook up some meth.
Just sometimes you got to do it.
I,
We're not going to condone that on our accredited episode either.
No, we are definitely not. I literally went to the pharmacy. This last time I bought Sudafed over the counter, I was getting some for Jem, and she was sick. And I was wearing, I would come back from the gym, I was wearing like a hoodie, and I just didn't look like very professional. And I asked for some Sudafed, and the girl looked at me, and then I hear her whisper into the pharmacist. I'm like, oh no, I'm getting profiled. I should have dressed nicer.
They're not going to sell Mike Sudafed.
No, they sold it to me, but it's fine. And of course, I was like, "Can I just get because we never buy it?" I was like, "Can I get the 96 count?" I was like, "Oh no!" I said the one thing I'm not supposed to say. It was terrible.
And you knew the exact amount.
As soon as I know,
nobody knows the random amounts that are in Sudafed except for
she's
somebody
like,
who's
"Oh yeah, this
abusing
guy's
it.
smurfing for sure." That's what they call it. So yeah, it was.
Is that what they call it?
Yeah, that's the street thing they call them Smurfs. They come in, they ask for Sudafed to fake like they have a cold. It's great.
Wow.
Man, we've done retail before.
I have. I can't say that. I can't say that I knew what the D meant, and I can't say I knew what a Smurf was, but I do now.
Yeah, well, we're all learning.
I'll finish up with the fact that there are intranasal anticholinergics that are used as decongestants. The ipratropium, you'll see it as Atrovent, but it's generic, so you'll probably just see the ipratropium. It can decrease rhinorrhea, but it's not as effective as the nasal steroids. So that is good to know.
Yeah, I just doing sign language at me. Yeah, AJ, you're 4. Sorry.
Just check it. There it
There
is.
he
There
is.
it is.
We switched up the interface that we're using for the microphones, and I forgot to switch his microphone from 5 to 4. So, oops, sorry, AJ. That's why he sent it so far away.
Yeah, well.
AJ's back. Okay. And then, so did you talk about the anticholinergics, the
Yes.
intranasal? Okay.
Yes.
Which one? I thought so. I just want to make sure. So the other oral agents that we have available, this one's prescription only, is the montelukast that we had mentioned. There's also one it's in the same class of being a leukotriene receptor antagonist, zafralukast, but that one's really only FDA approved for patients with asthma. And there's another product it's kind of similar, Xylutin, that is also approved for asthma. So you'd have to have that comorbidity. And there's also much better drugs to use anyway. But the one that we'll focus on is montelukast because you can use that in allergic rhinitis. It's typically well tolerated. In certain situations, and it's pretty rare, but it can cause a patient to have some abnormal dreams or even some onset of anxiety, and so it's usually something we only have to worry about in patients that have kind of a history of some sort of an anxiety disorder. Now there is a FDA box warning that was added in 2020, and it said basically to watch for behavioral and mood changes, and I think a lot of people were very nervous about that, and kind of especially patients or parents of patients were a little bit concerned that, oh, my kid is on this medication, is this, do I need to get him off of it? And it's something that I kind of read up on some of the FDA's sort of reasoning behind putting this on there. And because we've kind of always known about this, I feel like. It was something that I remember even hearing about in school. But they said that it's one of those, because it's rare, and it's extremely rare. Because of that, though, that not enough providers would talk to patients about it. Mm-hmm. And they wanted to make sure that providers were kind of having it at least in the background of their mind that they could happen, so that
I feel like I would see this pop up a lot with this drug prescribed a lot for adolescents. I don't know why it ended up that way. Maybe it's because of the asthma comorbid and stuff, but a lot of adolescents as well, which is I'm sure why it's important.
Well, and I think it has granules for different formulations that are easier for kids as well.
It does, doesn't it?
But yeah, I remember when I used to work for in a retail pharmacy back in the day, I actually dispensed quite a bit of the 10 milligram tablets to adults as well. I feel like.
Yeah, I did. Yeah. I guess I saw I just saw more kids than I thought than I anticipated I would. That's what I was thinking. And
it's for the most part, it's very safe, and it's something that again, I would take caution in patients that have some sort of behavioral health, like history of behavioral health, concerns or conditions. But it's not like something that just happens if you've been stable on it for the most part. It's not something we typically have to worry about. They really kind of added that box warning for the sole purpose of bringing attention to it amongst providers. However, my issue with it is not so much the side effects, but it's the effectiveness.
How well it works. Yeah.
Because, for instance, they've done a study where they compared nasal fluticasone versus montelukast plus loratadine. I don't know why they picked the two wimpiest drugs, but fluticasone by itself was still better. And so for me personally, I kind of tend to think about this for patients as a possible option who have allergic rhinitis and concomitant asthma. That's the patient population that I kind of think that, hey, this might be a more bang for my buck. I still would try to optimize the more standard asthma treatment options, but that could be utilized in that case.
Yeah, I think that there might be just a slight misconception. I don't know if it's among patients or providers that it's a heavy hitter because it's prescription. Yeah. Which most of what we're talking about are not prescription. I mean, some of the nasal sprays are, desloratadine is, but most of them aren't. So they'll maybe the providers know. I'm not saying they don't know. Maybe they know, and they're just I don't know, using it to placate them a little bit. Like, they'll come. I'm sure if they're going in for allergies for an appointment, then they're going to say, I've tried all the over-the-counter stuff. You try this or that. Oh, I've tried it all. So it's like, well, I've got this prescription thing that I can, give you a try. And even though they know it might not work fantastically, maybe there's, a little bit of, I'm getting a prescription, so it's going to work better. I definitely get that feeling from people sometimes. But yeah, as far as its actual effectiveness outside of being used concomitantly with asthma,
kind of limited.
Pretty limited.
Yeah, I think, and that's another example of what we were talking about earlier about making sure you review like administration of the nasal spray. There's so many other things I think it's skipped, and a lot of times it's due to time. But those are things, especially for the pharmacists. That's a good opportunity to kind of like make yourself useful,
right?
Where we have a little bit more time for the patient education piece. Make sure they understand how to use the meds.
Like if my dad went in and said, like, hey, I'm using this Flonase, it doesn't work at all, I'd be like, let me just demonstrate how you're using it, and then you would see that he's slurping it down his nasal cavity so fast it doesn't even touch the nasal mucosa. It just goes straight down his throat because that's how hard he's inhaling through his nose.
And then you take his and demonstrate on yourself to show him.
Yeah.
And he'd be like, oh, that's disgusting.
And then you get some sort of weird illness because you just used his
hand it back
Flonase
to him
after you did.
All right, so now you try. No, I'm good.
I'm good.
I'm more of a...
I'm good, weird doctor.
Yeah, I like to watch.
I don't need your COVID.
Yeah, like I knew pharmacists weren't real doctors. That's how that would go. All right, so intranasal decongestants. We talked about oral decongestants, but we also have some intranasal versions. We have phenylephrine as well. Now, like Cole was saying, typically think phenylephrine not very effective when it comes to. We're not talking IV phenylephrine either. We're in like an ICU setting. We're talking about that's very different.
Yeah, it pops up in other situations. We're talking about the OTC.
There you go. Very different. So in regards to nasal spray version of phenylephrine, there is the product Little Noses that I mentioned earlier that you can use in like very, very small children, and it's a very, very almost minuscule dose. It's basically an alternative option to like normal saline or something, but not really that effective, especially in adults or anything like that. We have an intermediate acting version because the phenylephrine is a very short duration of action. If you were going to use it, there's an intermediate acting one called tetrahydralazine, and it's I think Tizine is the brand name for it, and it lasts about 4 to 6 hours. But really, the one that most patients will get some use out of, and for especially our adult patients, is the oxmetolazine or the Afrin. That can last up to 12 hours. The really good thing about Afrin is the onset of action is quick. It's like tends to be like 5 to 10 minutes in a lot of cases. Mm-hmm. The issue is you want to make sure that you warn patients about stopping it after about 3 days or so.
Yeah.
Because it is very very prevalent to get rebound congestion that is horrible.
Really bad.
If you continue on taking it after that 4 or 5 day mark, and
then they'll just end up using it every day for the rest of their life to combat the
right.
Yeah,
I've had a few patients that are like, I've taken this every day for 6 months. If I don't take it, my allergies flare up. I said, I bet they do.
Well, let me ask you this because I don't know the answer. Tell me. After the 3 days you stop, when can you do it again?
I tend to think 3 to 5 days.
Maybe after a few half-lives when it's out of your system, you can do it again.
That's what I tend to think. I mean, I want to say a week would be plenty if you really wanted to be safe.
So this is not going to be your once daily seasonal or even perennial allergy medicine. This is probably going to be a lot more for if you're having a really bad situation or if you have a concomitant cold or something like that for a short period of time.
I tend to think of this as like, hey, this is my 3-day option while I'm waiting for my Flonase to really kick in and keep the inflammatory mediators at bay so that this is my relief while I'm waiting for that to happen.
It's like your acute medicine.
Right.
That only works for a few days. And then it turns on.
It's like if albuterol caused your lungs to close up after your 3 days. Think of it like that.
It's the exact same thing.
It'd be like you would not even want to use albuterol anymore. So anyways.
Yeah. So we have we also have another nasal spray, which is only really used in certain situations called cromolyn. It's a mast cell stabilizer. It's available over the counter. Usually this is used and could be recommended in certain situations when a patient has episodic symptoms or periodic symptoms, like if they're around dogs or cats and they have a predictable time when they're going to be around dogs and cats, like maybe they don't own one, but their girlfriend owns one and they don't want to be, sniffling around while they're at their girlfriend's house, then they might administer cromolyn 30 minutes before, and then that way they're not, crying or tearing up while they're at their girlfriend's house. It has to be dosed at 1 to 2 sprays per nostril every 4 hours to maintain effectiveness, so it doesn't last that long. Generally, it's pretty well tolerated, no notable side effects, but really it's safe for patients who maybe couldn't tolerate other agents or just need it for this short duration.
Yeah. And, we also have certain medications that in the case of like really severe, either, allergic rhinitis that's combined with asthma or nasal polyps, they have the immunotherapy, like Xolair or Ragwitek are options that are basically, they're just either like for Xolair, it's just, I'm not Xolair, I'm sorry. Olalair.
I was going to say, isn't that asthma?
That is asthma. I'm an idiot. I meant Olalair. Sorry, guys. Everybody at home's like, what is he talking about? Or
they tuned us out a long time ago, so it didn't really matter.
Was that?
They might have just tuned us out a long time ago, so it doesn't really matter.
I hope so.
Yeah.
That's my...
We can say whatever we want.
Well, unless they didn't tune us out. But the Olalair is 5 different grass pollen extracts, and this is something that is usually utilized in patients who are less than 65 years of age. It's contraindicated in patients with severe and unstable asthma because that basically you won't get as much efficacy and it can worsen that whole situation. But it has to be started once daily, 4 months before the expected onset of each grass pollen season, and then continued throughout the season. So it's probably a pretty large chunk of the year. And then Ragwitek is a ragweed pollen extract, again indicated for patients that are less than 65 years of age that do not have severe unstable asthma. And this one is started once daily, more than 12 weeks before expected onset of each ragweed pollen season, and continued throughout the season from there.
Yeah, I think these are kind of fun. It's like taking little bits of the actual thing to build up a tolerance, and bada bang, bada boom,
and see what happens.
Don't have a bad reaction.
And I guess since we're on this, because sometimes you'll see these as utilized for kind of adjunct like lifestyle therapies, as well as patients who have like recurrent like sinus infections and things like that. But there is I feel like more and more patients are starting to use like the saline rinses, like the nasal rinses, like the neti pots. They have some that are like regular sinus rinses. They just look like a regular spray bottle.
Yeah.
And then of course the neti pot has to show off and look like a genie
look like
lamp.
a literal
and you're like,
teapot.
this is for people who need to look ridiculous.
What's funny is it's totally unnecessary.
It's completely.
It doesn't have to look like that at all.
What happened was the person who designed it watched way too much Aladdin. He's a big Disney fan, and then that's what you get. But the take home, as far as like how effective that can be, it's kind of a little bit, kind of debatable especially as far as preventing infections and whatnot. But I will say, it's not going to hurt you to try it. But the one thing that you need to make sure patients are doing if they're using a neti pot or any other nasal sinus rinse, if they are asking how they are mixing it or where they're getting the water that they're mixing it with. Because most patients, I think, tend to just stick it right under the sink, get some tap water, because you can drink the tap water and be fine. However, your stomach is a little bit more capable of dealing with what could potentially be in that water than your sinus cavity that also is a direct shot to some neurological type anatomy. And so there's actually been case reports of like patients using an neti pot with tap water that got like amoebas and stuff in their brains. So I'll tell you what is not worth cleaning your sinuses out is that.
So you're saying I shouldn't use the rainwater that I collect?
Oh, you can use
in
that.
my
That's
neti
fine.
pot?
He's just trying to be environmentally friendly.
Yeah, good job, AJ. Saving the turtles. You might not be around to see the turtles live, but
So have you said it yet? Distilled water?
No, I haven't. Thank you, Cole.
It's a long lead up.
AJ distracted me. AJ, what are you doing? Thank you. But distilled water is the key. So to make sure that they are aware of that. I feel like every person I've ever mentioned that to, they're like, wait, what? They've just been getting another tap.
Yeah.
So whether it's an neti pot or any other sinus rinse, distilled water is key.
Have you used an neti pot before?
So I've had my nose broken a lot when I was a younger dude. And so when I try to do it, because I'd never had it fully fixed properly, so when I try to do it, it's not a steady stream. There's a lot of damage up in that sinus cavity, so it's probably great.
I've never broken my nose, but I've also never used a neti pot.
You should try both things. That way you should try it.
Just do it at the same time.
Well, sure.
I could break my nose with a neti pot.
You can get the blood out of there. Just clean it up.
That's disgusting.
It is.
Yeah.
But yeah.
Yeah. Since we're on that, I think why don't we touch a little bit on rhinocytositis a little bit, because that's where that probably comes in a little bit more. So this is a situation that is different from allergic rhinitis and is definitely going to be part of the differential, especially if somebody is having symptoms that are a little bit more severe. But it would be acute rhinosinusitis would be defined as symptomatic inflammation of the nasal cavity and the sinuses lasting less than 4 weeks. This can be caused by this can be caused by viruses. It can also be caused by bacteria. So there's a lot of emphasis on a wait and see approach if possible, to see if it's a virus, and that's probably from an antimicrobial stewardship standpoint. So obviously for allergic rhinitis, no need for antibiotics. There's no concern about it being due to a virus or due to bacteria. But this is an infection, and so it's either going to work itself out in 7 to 10 days because it's a virus, or it's going to have to be treated with a bacteria. And I think that's important just because it's going to be...
With bacteria?
Or
Antibacterial?
It's going to have to be treated with
a bacteria.
With an antibiotic. But I think that's important because, you'll hear patients say sinus infection a lot, and sometimes it might just be allergic rhinitis, or maybe it actually is a sinus infection. They're frequently, especially if they've had sinus infections in the past, going to be asking for antibiotics. So from an antimicrobial stewardship standpoint, when you're considering who to treat and who to do the wait and see approach for, it's very patient specific. But if you think that they could reliably return, or you could follow up with them in about a week or so, maybe provide symptomatic care and observe them for a week. But then if you don't think they're going to be able to, maybe you go ahead and prescribe an antibiotic, or just do it after that 7 to 10 day period when you feel like you can confirm it's bacterial.
Yeah. Look at, for those of you who are watching the video version, I don't know if you can read that or not, but it just says this kid that looks pretty nerdy in this, I don't know, some kind of weird
It's a meme
shirt. Yeah, and it says, this is what I give my PA students, and it says uses neti pot for the first time, gets pregnant.
I like how we have this extremely elaborate setup in here.
Yeah.
But instead of like having AJ post that meme right there for all the people watching the video, we're going to turn our laptop and show the camera.
Here's the thing about it, though, is, it was either that or we have missed opportunity to show some stuff. Yeah, we didn't have that preloaded up, so, oh well, next time.
You got to do it live.
Yeah.
You got to do it live.
So, I don't know, you think should we mention, I guess, some of the antibiotics?
Yeah, just mention a few that we could use just because it's part of the differential.
Yeah, so if you were going to actually treat a patient with bacterial rhinocytositis, the first kind of thing to consider is, hey, do they have penicillin allergy? And if not, then, you're looking at, is there any situation where we're worried about like poor outcomes? So like certain risk factors, like if they're older than 65, are they immunocompromised? Do they have other comorbidities like any kind of cardiac or diabetes or anything like that, renal disease? And if not, then we can kind of pick and choose what we want. We can either do amoxicillin 500 3 times a day. You can do 875 twice a day of amoxicillin, or you can jump right to the Augmentin with either 500 over 125 or 875 over 125 based on 3 or twice a day dosing. It depends on how worried you are about the gram negative coverage is in the beta-lactamases producing bacteria. If they do have any of those, sort of risks for a poor outcome or, pneumococcal resistance or anything like that, then you could consider that high-dose augmentin, the 2,000 milligram extended release tablets twice a day. You very rarely actually see that, but that is one that they recommend. Some other options if the patient does, if you want to avoid a penicillin, or you're trying to stay away from augmentin because of the GI distress or whatever, then you can also consider doxycycline 100 milligrams twice a day, or you can do a third generation cephalosporin will have about the same coverage as the augmentin, so you can do like cefodoxime, and there's in some patients even will end up being on cefodoxime plus clindamycin, which I would not recommend, but there is, depending on which bugs you're trying to cover, it does happen sometimes. I typically think cefodoxime by itself is good enough. And then if there's no improvements, one, you want to look at your differential diagnosis again, make sure that it's actually what's causing it. And if you just think it was resistant or something like that, then you would potentially treat with another oral antibiotic from a different class than was used the first time around, and that's where you could consider like a respiratory fluoroquinolone, so like levofloxacin, moxifloxacin, or a third generation cephalosporin plus the clindamycins. That's where I would tend to save that one for. And then from there, if you're still not getting improvement, send them to a specialist to get some imaging done. Figure out what in the world's going on, because it's pretty rare to see that. But yeah, so there's some breakdown of some treatment options. We can go into a lot more detail of that later, but just for the heck of it. Yeah,
we'll hit it in another episode. But there are some common bugs. You might have kind of referenced some of them, but strep pneumo is going to be the most common, along with H. flu. But you could have some other bugs that are causing the infection: MCAT, Staph aureus, different anaerobes, and Streptococcus species. But those first two are definitely the most common.
Yeah. So there you go. AJ, we missed anything?
48 hours is how long after the 3-day course of Afrin you can take it again.
Oh my goodness. Great.
Good job, AJ.
Look at that.
Look at that.
Customer service hotline.
That's fantastic.
The customer service hotline.
Did not know that at all.
They'll tell you.
Oh, you called it? No, you did not.
Reddit told me.
Okay. Well,
great.
Reddit never lies.
We're citing our sources now.
Let's put that. Let's put that with an asterisk by it until we verify that the Reddit author was some sort of a healthcare provider. But yeah, cool. Thanks, AJ. And then make sure you guys check out our other material, whether it be social media or Patreon. If you guys like the podcast, or you want a little bit different vibe of the recordings, so it could be, with the Patreon stuff, it's all like the lecture, like traditional boring lecture stuff. So if that's more your style, which I get it. If we distract you too much with our tangents, that might be something you like. So check that out. Check out the tips and tricks and clinical pearls and stuff we put up on the social media platforms. And we got to talk more about it. I want to roll out some kind of like a live case thing that we can start doing, and people can call in and participate and all that. It's still noodling around up here. I'm just got to figure out how we can work that, and we have some the capabilities now of taking live calls on the air, so we got to figure out how we can utilize that.
Yeah, just make it like a 3-hour radio show.
Yeah,
you're just like,
I'll change my voice like they used to do. Like people thought you had to do that. So ridiculous.
Mike and Cole.
Yeah,
5 o'clock rush.
Could you imagine? That'd be so annoying.
Yeah,
and. So yeah. Anyways, we got some stuff that we're going to be working on. Hopefully, that you guys will enjoy. But thank you guys so much for listening, and everybody who's stuck with us this long. If you have any questions for us, hit us up in the emails. Or any of the social media platforms. Again, make sure when you're done with this episode, if you are a freeCE.com member, an unlimited member, then check out the post-activity test, get your credit for this, and make sure you keep the pollen password in all caps. I've gotten a few messages from people. I don't know how I'm the IT guy for this thing, but
password doesn't work.
Password doesn't work.
It's like, okay.
Oh, guess what? Your password doesn't work. And very annoyed with me.
I like how they email us directly.
I know. I was like, we're just the podcast guys. I am not the IT, but I end up just helping them anyway because I feel bad. But yeah, so thank you guys for sticking with us, even though we go off on these tangents that some of you hate. But we'll see you guys in the next episode. AJ, see ya.